Welcome to the Science Sprint. In the next 10 minutes, we'll turn a famously tangled pathway into an explain-it-to-your-patients diagram. 1 30-second definition. MTHFR stands for Methylenetetrahydrofolate Reductase, the enzyme that converts 5,10-methylene tetrahydrofolate into 5-methyl tetrahydrofolate, the active folate needed to remethylate homocysteine back to methionine. If you just had a med school flashback, good, you're warmed up. 2. The one-carbon highway. Think of this as a one-lane highway. Folate enters, picks up a methyl hitchhiker, and hands that methyl tag to homocysteine, turning it into methionine. MTHFR is the toll booth gate. Gate open equals traffic flows, homocysteine stays low, methylation hums. Gate slow equals traffic backs up, homocysteine rises, methyl donors run low. 3. Common polymorphisms. 2 common single nucleotide polymorphisms, or SNPs, dial that gate speed down. C677T, meaning a change from cytosine to thymine at position 677, swaps alanine for valine, makes the enzyme thermolabile. Being heterozygous with a C and T allele results in a reduction of activity by about 20 to 30%. Being homozygous for the T allele results in a reduction in activity of about 60 to 70%. A 1298C, meaning a change from adenine to cytosine at position 1298, subtler regulatory change. Being homozygous for the C allele results in about a 20% reduction in activity on its own. Being compound heterozygous with a 677T and a 1298C variant leads to about the same activity reduction as being homozygous TT at position 677. Key line to remember, 677 steals raw horsepower, 1298 tweaks the throttle. 4. Prevalence snapshot. These aren't rare disorders, they're ethnic fingerprints. About 10 to 15% of North American Caucasians are 677 TT, 25% of Hispanics in the US carry TT, roughly 50% of everyone worldwide holds at least one risk allele. So when a patient says, "Doc, I have the mutation," your mental response should be, "Join the club." 5. From variant to phenotype, homocysteine. On a folate-replete diet, TT nudges homocysteine up by about 2 to 3 micromoles per liter, clinically modest. But pair TT with low folate or low B12 and the gap widens rapidly, sometimes past 20 micromoles per liter. Clinical pearl number 1. The gene loads the gun. Nutrient status pulls the trigger. 6. Severe versus common. Important distinction, rare biallelic loss-of-function mutations cause classic homocystinuria. Homocysteine greater than 100, early strokes, marfanoid habitus. Common SNPs, 677, 1298, cause at most mild enzyme slowdown, very different clinical stakes. 7. Why the enzyme is thermolabile. Mechanistically, the alanine to valine swap destabilizes the flavin-adenine dinucleotide cofactor pocket. At 37 degrees Celsius, the mutated protein partially unfolds, ergo thermolabile. Give it extra riboflavin and the pocket grips flavin-adenine dinucleotide tighter. That's why a simple B2 supplement can sometimes shave homocysteine a point or two in TT carriers. 8. Quick myth check. Myth: TT can't use folic acid at all. Fact: TT converts folic acid 15 to 20% less efficiently, but still converts. Myth: 1298C is as bad as 677T. Fact: 1298 alone rarely elevates homocysteine. Myth: 1 SNP explains every chronic symptom. Fact: multigenic, multifactorial, you still need a differential. 9. Analogy for patient education. I tell patients your methylation cycle is like a 6-cylinder engine. An MTHFR variant pulls one plug wire halfway off. The engine still runs, just not at peak RPM. Unless you top up the high-octane fuel, that's your folate and B vitamins. It clicks instantly. 10. Clinical bridge sentence. So here's the clinician's bottom line as we head toward evidence. A common MTHFR SNP is a mild efficiency defect only when unmet nutritional demand exposes it. Memorize that. You're framing for every patient consult. You now have the biochemistry and the allele frequencies. Next, let's ask the hard question. Do these variants actually cause disease in real humans? Spoiler, sometimes yes, often no. Jump to segment 3 and we'll separate signal from noise.